All right. Okay, everybody. Good afternoon. This is Professor Dunham, and this is exam 2 review. All righty. So like I always do, I'm going to share my screen. I can see you raise a hand. If you need to use a reaction button, it's down on the lower part of your screen, and it has you can raise your hand and ask a question. If I ask you a question, I can also see who's talking back to me, so I can see what's going on. Okay, so I'm going to share my screen and get up my beautiful mommy here. And we're going to do chapter 6, 7, 8, and 9. 6 is about labor, birth. 7 was about what, pain management, wasn't it? And then 8, what was 8 about? I think it was complications. And then 9 is taking care of the family after birth. All right. So on every test, no matter what test you're going to take, you're always going to have a question on culture. Okay, that's just a given. So on those kind of questions, you want to make sure that you read them very carefully and make sure that they're asking, what are they asking you? Okay, so what we're going to be talking about is the influence of culture concerning birth practices. So nurses, now it doesn't matter if you're a maternity nurse, you're a pediatric nurse, you're a med-surg nurse, doesn't matter. We're always sensitive to the specific needs of our patient, okay? And I put that in red because I want that to stand out to you. The nurse's role is to be active and therapeutic listener. Remember, we have one mouth and 2 ears. My teacher always taught me that. And so that means I'm going to listen more than what I'm going to say, correct? Okay. And then the nurse demonstrates cultural sensitivity. Okay, cultural sensitivity. And what a lot of questions will kind of trick you up is sometimes they ask you, is the nurse being sensitive or non-sensitive? Okay, and that's where it gets a lot of students. All right, so you're going to adapt your care to specific groups and cultures, okay? They all have their own little culture. In labor room, we are very much into that because we want to keep our patients cool, calm, and collected, okay? So labor in itself is hard enough for our patients. And so we don't want to create any barriers, and we want to make sure we work. And I do that all the time with my patients, guys, okay? I once had an Indian tribe in my labor room. Now, you may say, oh, my gosh, but I'm telling you the absolute truth. She asked me, and she said, I would feel better if I could have my tribe to come in and do a little chant for me. And I got the okay from above, and I was allowed to bring the whole tribe in. Okay. So they all come around the bed and they did their culturistic, tribal dance and song. And it made her so happy, guys, that I thought that was the best decision I have ever made on that kind of decision. And I'm gonna let you know, she did absolutely beautiful. She didn't have any medications whatsoever during the labor. She had a beautiful natural birth. We kept her walking and doing in all kinds of different positions, and we did great. So you see what I mean? I use that example to show you as a prime example of being sensitive to the needs of the family. Okay, so here we also have, we're very diverse United States. We have a lot of different, cultures. We have a lot of different languages. So there's always a good question on exams about an interpreter, okay? Yes, you use an interpreter where appropriate, and it's because it shouldn't be a family member, okay? Now, a lot of times we deal with a lot of sensitive questions, especially in labor room, and so there shouldn't be a family member interpreting. Plus, two, do I really know if that family member is interpreting what I'm saying to her, okay? So I have that always in the back of my head thinking, So what I did is I always use the blue phone. In our Florida hospital, we have the blue phone. It could be a different color in your hospital, but it's a phone that we use, and we plug it into a phone jack. It has 2 receivers on it. I call in, there's a certain codes, and I get an operator, and the operator identifies and says, what language do you need? I go, thank you. I need Chinese. Okay, wonderful. I get hooked right up to a person who can interpret. He speaks beautifully Chinese. Is that good? That's good. Okay, Florencia, go ahead and put yourself on mute. And then you have dietary practices. And this is where I came into a situation. I was a very young nurse on postpartum, and I was trying to give my patient, because I remember my teacher telling me, you know, make sure your patient has plenty of fluids, Irene, plenty of fluids. So I said, okay, she got to drink her fluids. So I was trying to get this lady to drink cold water. Okay, but she was from the Chinese culture where they don't drink cold water after childbirth. Okay, so they drink hot water. Okay, so all day long I'm trying. I really felt bad that this lady's not drinking and adhering to what I'm saying. I think, what am I doing wrong? Her husband comes in and tells me, and I went, oh, that's right. I'm so sorry. And I really felt really small. And I said, I'm very sorry. And I went and got her warm water, and she drank all evening. So you have to be aware. See, that's why I'm making you aware of these. Now, if you want to, you go back in chapter 6 for specific cultural practices, but I'm giving you the highlights of what you need to know. Okay, so let's do like a little brain teaser. So this teases your brain. All right, so which of the following nursing actions demonstrates culture insensitivity in the care of the laboring woman?
B.
B, absolutely correct. Okay.
Oh, insensitivity. Darn.
Very good. Very good. So you can see how I'm demonstrating to you how the question could be, and you have to be aware. Okay, good. All right, so let's talk about the birth process. All right. So we got the 5 P's. I know your book says I think 4 P's, but L&D nurses, we put the 5 in there because we number 4 is pole position, so we kind of stick that in there. But anyway, we're going to get back to what the powers are. The powers are the uterine contraction. Okay, now understand this. Okay, so the uterus, right? And you have the uterus, and you have on very top of the uterus is called the fundus. Okay, and so you have this uterus, and this is going to be what has this organ that is made up of 3 different muscle fibers, has to contract, okay, in order to dilate that cervix, okay, and to open it up, okay? So that's your uterine contraction. You have to have those, okay? So now, part of the contraction, there's like 3 different, definitions we have with each contraction. We have frequency. So frequency means how often your contractions are coming. Don't you ever hear that? Mrs. Jones, how often are your contractions coming? Oh, they're coming every 5 to 6 minutes. Okay, that's frequency. So the definition is from the beginning of one contraction, okay, to the end of that same contraction, okay? It's just frequency. Oh, no, excuse me, that's duration. Okay, scratch that off. Frequency, I've been saying this so many times in the last few days. So frequency is beginning of one contraction to the beginning of the next contraction. Did you all hear me on that? I hope so.
Yes.
So the beginning of one contraction to the beginning of the next contraction. Okay. Now duration is how long that little contraction is doing. So that would go from the beginning of one contraction to the end of that same contraction. That's duration. All right, everybody got that? Okay. Because there's probably a question about frequency and duration. Okay, so you want to get that straight. So, excuse me. So frequency is at the beginning of the contraction, and it goes to the beginning of the next contraction. Duration is the beginning of one contraction, goes to the end of that same contraction. Okay, now intensity is how strong they are. Now, intensity could be mild, moderate, or firm. You have to use palpation, 2 little fingers on top of the fundus of the uterus, and you can feel. So if it feels soft, it would feel like your nose. So touch your nose. That's a mild contraction, by the way. If it feels like your chin, feel your chin. That's a moderate, okay? And if you feel the forehead, that's a firm contraction. Okay, so that's how we do intensity. And I can tell you, that's how we teach all new nurses. Excuse me. All right, so that's your contraction. All right, everybody clear on frequency, duration, and intensity?
Yes.
Yes, okay, good. All right, so let's move on to the passageway, which is your passage the baby's going to come through the pelvis. And so the gynecoid, as we learned previously, is the most favorable for vaginal delivery. Okay, and then you got the passenger, which is your fetus. The position, you got an OA, which is occipital anterior, which is most favorable, occipital posterior, which causes a lot of back pain, and then you got occipital transverse, where the head is just sideways. It's coming down that way, and that's pretty hard to come through when there's a certain diameter involved. So we like the baby to be in an OA position. They can deliver an OP vaginally, no problem, but it causes a lot of back labor. And so you would be flipping your patient quite a bit because, her back would be hurting. And you could use sacral counter pressure for OP position and catch your patient up and walking in the room, so that basically, hopefully, we can turn that baby's head. Okay, and then you got psychic, which your patient needs support. No doubt about it. All right. So this is what we're working on. We have a beautiful baby. We have a mom that's going to be in a beautiful labor mechanism, so we can have this baby. All right. So this is where we're going to be looking at. Let's see. This is, hold on just a moment here. This kind of got out of whack here. Yeah, that's what I wanted. Okay, I'll come back to that. So again, let's go over contractions. So you need contractions to efface and to dilate the cervix, okay? And then you have a phase of your contractions. Okay, so we have the increment, peak, and decrement. So let me see if I have that. Yes, here it is. Okay, so here's your increment. So again, going up, she's going to be doing slow chest breathing. She goes up to the peak of the contraction or the acme. Okay, same thing. It's the top portion. She could be doing her breathing, such as more of a pattern like, and it can get very fast. And then as soon as she starts to come down on the decrement, you want to go ahead and do slow chest breathing. So yes, breathing is considered a non-pharmacological means of pain control, and it's very, very vital to the labor process. So we want to make sure our patient's always breathing during the contraction. And here it is. Here's your duration. So beginning of one contraction goes to the end of that same contraction. And then frequency with beginning of one contraction to the beginning of the next contraction. So there's your contraction cycle. Okay, so, we already talked about that, so we're in good shape. So let's see, this is here, write this down so that you can write it down in your own words later. What is the definition of duration? What's the definition of frequency? And how does the nurse assess intensity of the contraction? All right, I think we got that. Now, Braxton Hicks contractions, on the other hand, are just irregular contractions that begin in early pregnancy and they intensify as she gets closer to term. So there's always a question about a Braxton Hicks contraction, okay? And what you have to remember, they're irregular contractions. When they happen, let me tell you, when they happen in early pregnancy, it's very scary for the woman because she doesn't want to lose this baby, okay? And then we try to get her hydrated, make sure she doesn't have a UTI or anything. And then as she gets closer to term, those same contractions, these Braxton Hicks, can be, they it can be bothersome. Let me put it that way. They bring the woman to the hospital quite often, And sometimes, you know, you can hear the nurses say, oh, we got Mrs. Jones, frequent flyer is in here. Okay. That's because she's, bless her heart, she's having all these Braxton Hicks contractions, but they're not dilating the cervix, guys. And that's what we look for when we look for a patient that's in true labor. Okay. True labor. So write that down, true labor. So with true labor, you're going to have regular rhythmic contractions. The frequency could be like every 3 to 4, but they're consistent. Duration can be anywhere from, you know, just according to what phase of the first stage of labor they're in. But usually, we like our contractions to be like 60 to 90 seconds in duration. And then the palpation, the intensity would be how you palpate, either mild, moderate, or firm. Okay. And then you know she's in true labor. Okay. All righty. So let's talk about how we efface. So this was a great slide we talked about earlier. And you can see the cervix here. So when you understand, okay, what's going on with the uterus. So the uterus is contracting. So you can if you understand all that, you can understand the mechanisms going on here. So here you have an internal os and you have an external os. You have the cavity of the cervix right in here. Okay. So when you're in labor, the internal os starts to ascend, go up. And then your external os starts to go up, and then it starts to open up. Okay, so here she's in labor, and you can see the internal os going up, and you have your external os right here opening up, and then everything is going to get real big, real wide, and here we go. So you see your external os now, how nice and wide it is, and then you have the internal os going up and very soft, and going up, so it makes more room for the head to descend. Okay, and remember, on the ischial spine, you're at a 0 station, so we want this head to come down 0 and then come down to +1, +2, +3, +4. And then you can see here that external os is completely open here, okay? And you can see how the internal os now, so the external os almost comes up to meet the internal os. So that's when you know when she's having good contractions, is that you start seeing this dilatation and effacement of the cervix. Okay. When we talk about different lies, okay, we have a transverse lie and we have a longeal lie here. So you can see here how the baby's cephalic position right here, okay? And then you can see the transverse lie here. Well, the transverse lie, you know, is going to get sectioned. And this little baby here is just fine. He's cephalic position, which is head first. So we'll be able to birth him, no problem. And all the lie means is how they are in position to mom's spine. That's what that means. Okay. So we're moving right along here. Let's see here. Let's go down to here. So this was in your book, and I bet, you know, you kind of looked at it and go, oh, no, no, no. But what it's showing you is the different positions also. Basically, you have a complete flexion here. You can see how this baby's nicely fitting in. And then you have the presentation here, a full extension. And then you have a flexion. See, when you have something like this is hard. This is hard for her to labor and to bring back down this baby. You can see the difference between this baby and this baby. Okay. Now this baby here is in a shoulder presentation, and so his shoulder. This would be a C-section, and then you have Mr. Frank Breach, and he has got his toes up by his head. Okay. And then you have a full breech, and he's nicely tucked, but guess what's presenting? Okay, in both of these, okay, is his buttocks, right? And so these will be sectioned, okay? And this one was presenting is his shoulder, okay? So you can't deliver a baby that way. And this guy here decides to take, he was real eager to be born, So he's already ready to walk. So we've got his foot coming down. That's called a single footling breech. Okay, all right. So those are presentations. And then one of my favorites here is the position, presentation and position. So let me make this a little bigger for you. And all it is it shows you, start here at mom's pelvis, and it shows you here the interior, okay, of her pelvis, and then here's her posterior. When you have a baby and he's saying OA position, that means his occipital, the back of the baby's head. See where I'm pointing to my head here? The back of the head is now presented to mom's interior. That's all it is. Back of his head is facing mom's interior. So when you have a baby like this position, he's nicely tucked down, okay? And he's ready to be born, you know? His head first, which is good. That's the collocephalic. And then his chin is, down, and he's tucked in nicely, and he's ready to be birthed. He's ready to make that passageway. Okay. And then you have the another one is called LOA. And all that means, when it means ROA or LOA, that means his back is going to be toward mom's left side. On this one is going to be his back of the baby is toward mom's right side. That's what that means. But OA is a great position to be born. And then you have occipital posterior. Now, you can see this back of his head is facing mom's coccyx, the back of her, okay? That's painful. You have a lot of pressure. You have a lot of pressure from the contraction. It's like, let me tell you, a good contraction puts out 50 millimeters of mercury. That's a lot of pressure. And then you got a baby. And if you got a 7-pound or 8-pound baby in there, that's a lot of pressure. And so this back of his head is being pressed against her coccyx. So that's why she's got such back labor. So write down OP causes the back labor, really hard back labor. And we can get this baby through, but it's a little harder. So her labor may be elongated, may be longer because of OP position. Okay, and she'll push, but the pushing may be longer because of the position of the baby's head. So, and that would really tire mom out. Okay, so this baby can be birthed, no problem, but it takes longer. And then here again, you have the left occipital posterior. Now this one, this kilo guy, he is occipital transverse. The back of his head is laying right point transverse in her pelvis. Well, that's pretty hard. Now, when they first start in labor, they first start out like this way, but then with the contractions will move them the way they should. So you've got this occipital transverse position, okay? And then your hair. Now, it's really hard. What we do on that kind of situation is we'll go up and do a badge exam, and we'll go ahead and do a badge exam and try to move the baby's head. And a lot of times we can flip them. You know, we go up there and just flip the head and put him, hopefully go into OA position. And that would be great. Okay, sometimes they go into OP. We try to go into OA. All right. And then sometimes I'll tell you, bring my hand out. I say, okay, we got it, and then we go back in and she's back in OT. It's called persistent OT position. Okay. So we're moving right along. So another part of those P's was the psychic. And remember, this is really important. And a lot of people just kind of put this to the side, but it's really important because it not has to do with her cultural, but also her individual values, that how she's going to cope with the childbirth pain. And I mean, I had ladies very stoic in labor, didn't say a word. And it's very hard to actually, to communicate when they don't even talk to you, but they just take every contraction and they internalize it, and they're dealing with it. Okay, that's how they deal with the labor. Everybody is so different when it comes to pain, associated with labor. And so you have to always keep that in mind too, okay? All right. Okay, now if she's by herself on this, let me go back to here. I want to make sure I conquer this. If she's by herself, she can hire a doula. So DOULA, write that down. You will see that again. And so the doula is an advocate for the patient. Okay, so a doula, what she does is that she'll support, whatever the patient wants, she'll support it. And they usually get together before she goes into labor to have all these discussions and her philosophy of what she wants. And it really works very well, especially if you don't have a real good support person with you, then a doula is very good. Okay, and you don't have to be a nurse to be a doula. You can take the course, and then you have to have hours, at the hospital working with patients. Okay, so we talk about impending labor, all right? That's when patients come to you and they want to know, am I in labor or am I not? And then, you have to figure out they're in true labor versus false labor. So these are signs that maybe labor may be coming. All right, remember I talked about Braxton Hicks contractions, okay? Those are basically, I always said to my patient, even though Braxton Hicks are irregular contractions, they really don't dilate the cervix. I said, but at least your body is getting ready, okay? That means that you're starting to release oxytocin from the pituitary. And so that's always a good sign. Increased vaginal discharge. Yeah, that could be, we get a lot of discharge during pregnancy. It kind of increases because it starts to lubricate the vagina for the baby to descend. All right, and then you get bloody show. And bloody show is the mucus plug that is basically dislodged from the cervix. So that's a good mucus plug comes out. It's real thick. It's blood with mucus. And now you don't need it anymore. Gotta get rid of it. And it's usually up in that cervix, the cavity of the cervix, and keeping out any bad bacteria from going up into the uterus. And now that's being released. So the body is starting to get ready for true labor to start. Rupture of the membranes is pretty obvious sign. So she might not go into spontaneous labor, but that's impending labor. So if she ruptures, we need for her to come to the hospital, okay? Because we only have 24 hours to get this woman delivered from the time of rupture. Energy, oh, they get a whole bunch of energy. I want to do everything in the house. I want to do the laundry, mop the floor, and everything I didn't want to do before, I do now. They go, ooh, she may be going into labor. All righty, so let's go over another important concept for you to understand would be station of the baby. You might have a question on this, and what you want to know, you make sure you know and understand is here's your ischial spines. Okay, so this is the pelvis, okay, and here's your ischial spines. And these are really bony prominences. They stick out. When you go up and check somebody, and you can really feel these. And then right at the ischial spine, that would be considered zero station. And anything above the ischial spine would be a minus, -1, -2, and going up. And then anything below the ischial spine would be plus, +1, +2, +3, +4, +5. We deliver. So this is how we can tell where this baby's at. Okay, and it's a really good thing. You have to get trained. You just got to do a whole bunch of value exams to get really good at this. But you can really feel and anything above it, that baby's higher up. Anything below it, we're going to have a baby real soon. So that's called station. All right, let me look that a little bit here. Okay. All right, so I put a slide together showing the comparison of false and true labor because I talked about this a little bit earlier. We talked about contractions. Okay, so for instance, I'm the nurse and I'm in the triage. I've been assigned to triage for the shift. Okay, I have a patient that comes to me and she thinks she's in labor. So, okay, I go ahead and put her on the monitor. I take her vital signs, baby's heart rate between 110 and 160. So we're good. I see some accelerations of the heart rate on the monitor, which is good. Okay. And I see a contraction pattern. It looks like it's every maybe 3 to 4 and lasting maybe 60 to 70 seconds in duration. I go, this is pretty good. Okay. So I check her and she's like 2 centimeters, and maybe she's about 80% effaced. And the baby is a little high yet. He's about -2 station. Okay. So I said, what I'm going to do? I'm going to see if we get these contractions to get a little closer together and get a little stronger. So I'm going to send you out walking. All right. So this lady, I send her out walking. She comes back in 30 minutes. I check fetal heart tones. Everything is good. She's good. Send her back out for another 30. So now I got to, when she comes back in, I'll have a total of 1 hour. Okay. When I check her, she's now, say, 4 centimeters, and she's 90% effaced, and the baby's at a 0 station. This lady definitely is in true labor because she progressed with her dilation and effacement of the cervix. Her contractions became stronger while walking, okay? And they got a little closer together. The frequency now is 3 to 4 minutes apart. All right. So walking really does do a lot for the laboring woman. So we go ahead and admit it. All right. Another thing she could have too, she could have had some bloody show when she was walking around. And bloody show is okay. It's blood with mucus. And that's a pretty positive sign. So that just shows that because the cervix is a very vascular area, guys. It bleeds when it starts to open up. And so that's what happens. So that's a good sign. Okay, so I'm going to put her in labor room number 2, and Nurse Clarincia is going to take care of her today. Okay. All right, now Nurse Emily gets another patient, and this patient, her contractions are irregular. Okay. And she wants to be in labor so badly. She goes, Nurse Emily, I want this baby. I'm so tired of being pregnant. And, Nurse Emily says, oh, well, let's just see. Let's send you out walking after I check your vital signs and listen to the baby. Okay, everything's good. I'll send you out walking. Okay. So she's out there walking, and she comes back in 30 minutes. You check if fetal heart tones, and they're fine. You send her back out for another 30. And she comes back in and she goes, oh. And I said, and Nurse Emily goes, well, did the contractions get any more regular? And she goes, no, actually they kind of dwindle when I was walking. And so Nurse Emily checks her, and there's been no change in the dilation or effacement of the cervix. Now, Nurse Emily has to tell this patient to go home. So, and the patient looks at you, Emily, saying, I don't want to go home. And you have to say, well, you need to go home, take it easy, try to get some sleep, maybe take a nice warm shower, because, that always helps. And you'll be back. You'll be back when your contractions become regular, or your bag of water breaks, or you see some bleeding. You'll be back. And she leaves. She signs her discharge papers, and she's out the door. Okay, so that's the difference between false labor and true labor. And what I described to you truly does happen, and patients will bargain with you to stay with you. Okay, so how about a brain teaser? A laboring woman is uncomfortable, and her labor has slowed down. All right. So which instructions should the nurse give to the client to help stimulate her labor?
D.
D.
D. Yeah, encourage that woman to what? To walk around, to ambulate. And that's how those questions are asked. Okay. So let's get down going here with the fetal monitoring. All right, because everybody's got to understand what's happening because the baby's going to talk to us. Okay, this is how our babies talk to us through their heart rate, and we can see it through the monitor. Now, when I first started out in labor room, these monitors were just coming out, guys. So I've been doing this for a while. So we get so used to these machines now. Okay, but when I first started out, I had to use a Doppler, and I had to listen before a contraction, during a contraction, and after contraction. So it was pretty difficult to labor somebody. It was very, very a lot of work. Okay, so here you have the monitor. So you can see here the fetal heart rate. It's on the low side. It's okay. So remember, 110 to 160 is normal. So okay, I'll take 113. The 22 is resting tone of the contraction, and which is like resting tone or relaxation is between the contractions, I should say. And then you have blood pressure here, mom's blood pressure, and then here's her heart rate, and she's working hard. Okay, and so, and this one would be if you had a twin. See, you have another plug-in for a twin electrode here, but we don't have twins. All right, so here you have the strip, and let me just center this for you. And here you have rate acceleration. Accelerations are A-OK, correct? Here you have, you see this, and I'm going to make it real easily. This is the variability. And variability is the beat-to-beat fluctuations of his heart rate. So it's always good to have good beat-to-beat, like 5 to 25 beats per minute. You know, it's good. You want that. So I say squiggly lines are always good. Okay. Straight lines are not good. Okay. And then you have another acceleration here. And then you have another one there. So this baby is doing fabulous because here she had a contraction. See, here's a contraction. And then here you go. So here, this would be your increment here going up. The top is your acme or the peak. And then the going down would be your decrement. Okay. So with the contraction, I look at the fetal heart rate. And my baby's telling me right here, hey, nurse, I'm A-OK. All right, because I'm having good accelerations with mommy's contraction. Because when mommy has a contraction, it puts a lot of pressure on the baby. And then the baby is actually, his cord actually gets compressed. Okay. And so during a contraction, the baby has to take like a deep breath. He goes, okay, I gotta hold my breath. She's having a contraction. Okay. And as soon as the contraction lets up, then the compression to the cord lessens and gives the baby more needed oxygen, which is what we need. And then he does really good. This baby's a pretty healthy baby, as you can see. Okay. Anybody have any questions about that? Okay. I'll move along. Here's another setup with a patient in labor. And here's your monitor. So this one here, the bottom one, this is your ultrasound transducer. This picks up their fetal heart rate. And this one is your TOCO diameter. And we shortened it by saying TOCO, T-O-C-O. And we put that on the fundus of the uterus. So the top portion of the uterus is right here. And that's where we put it. Because that's where, when the contraction starts, it'll start there. And the monitor will pick it up and then sends a signal to the monitor, and then it prints up. We can see it beautifully on the monitor. Great invention. Really good. All right, so she's laboring, and so here we go. Here's another monitor, and this one's made by Philips. Same thing. And again, here's the fetal heart rate. This is a higher resting tone. That tells me that this contraction is starting to go up, which is nice for the support person. So we teach the support person what to look for. So I say, when you see this number go like 22, 23, 24, that means the contraction is going up. And then he or she can help the patient to start her breathing, which is really nice. All right, and then here would be the printout of the fetal heart, her blood pressure and her heart rate. And then here's your printout again. Okay, this lady doesn't look like she's really in labor. All right, so when you're evaluating the fetal heart rate pattern, okay, so remember that veal chop? Okay, so you got your baseline, which you have to know, 110 to 160. Okay, anything below 110 would be fetal bradycardia, means it's going slow, brady, slow. Anything above 160 would be tachycardia. And we talked about the baseline variability, okay? And we classified under moderate, marked, or absent. Well, moderate is like 5 to 25 beats per minute, which is great. Marked would be greater than 25 beats, and absent would be 0 to 5, okay? Which never good. If you get absent variability, your baby's trying to tell you, I am in trouble. Okay, I'm not going to last much longer because I'm not getting the oxygen, not getting the blood perfusion. And remember, blood carries oxygen. So I'm not getting what I need to survive in here, nurse, so get me out. And then we have these different variations in heart rate. Accelerations are A-OK. And then you have early deceleration, and you have variable deceleration, and you have late decelerations. Late decelerations are a non-reassuring pattern. That means I do not like. That means, like, remember this way, it's good to be early to dinner, okay? It's bad to be late for dinner, okay? Or you can put it this way, it's good to be early for class, but it's very bad to be late for class. Okay, let me help you remember that. And then you got prolonged, and then you have recurring deceleration. So let me just show you here. Okay, so here's my veal chop. Okay, so when I talk about variables, I'm talking about a sudden drop in heart rate. Okay, so let me go to my whiteboard here so I can show you this, because this I think is important. Okay, so here, all right, so I'm gonna load up my whiteboard, and I'm gonna use my pen. Okay, so I'm gonna do my contractions. Getting better at this. Okay, all right, now I got my pen. So I have a heart rate of 120, and my patient is in labor, and she's starting to feel some pressure, which is a good thing. And I see my heart rate. Yeah, I got some squiggly lines, so I've got moderate amount of variability. And then all of a sudden now, his heart rate goes down. But it comes right back up. Okay, as soon as that contraction's over. So the heart rate, this is an early deceleration. This is where the nair, which is the lowest part of the deceleration, is right along with the top of the contraction, the peak or acme of the contraction. Okay, again, this is an early. So this is the earlies are caused by head compression. That means the baby's head is being pressed down, okay, press against. Imagine you're coming down a passageway, guy. Think of it. You're coming down the pelvis. And now your head has to mold, which it does because the suture's kind of fold in, and he's able to mold. And when he comes down, though, he's coming down so far that his head, he causes like a vagal response. So his heart rate goes down. All right. And then she has another contraction, and I see it again. Oh, okay. Maybe it's not so demonstrative. Maybe it comes back up like this. All right. All right. Again, this is an early. This the lowest part of the deceleration is with the acme or peak of contractions. Okay. Now, that's an early head compression. Now, this little baby decides now, okay, go on for the next contraction. What's going on with this kid? All right, he had now a deceleration after the contraction. See the nair? And when I speak about nair, I'm spelling it Nair. That's the lowest portion of the deceleration right in here. See here? So here my nair is clearly after the contraction. All right? This is a late. This is not good. Not good. Bad. Okay. And then he loses variability. Okay. It's real bad here. And here you see it again. He starts to go down, and then the lowest portion of the nair is after the contraction. That's a late deceleration. This is non-reassuring. I'm not assured at all. I hate it. Okay. I don't want this. This is what I try to avoid, because if you keep this having recurrent late decelerations, your baby is going to get acidotic. Okay. All right. So let me take this off. Let me show you now what variables look like. Okay. Now variables they have a configuration, and it could look like a V. It could look like a W, and it could look like a U. All right. That's why they are called variables, because they vary. All right. Variables are caused by cord compression. So maybe the baby, is laying on his cord. Okay. Therefore, his heart rate would go down. So when he does that, something like that, here he is, okay? Okay. And it would be a sudden, when you're gonna lay on something, lay on your cord, you're gonna have a sudden drop in his heart rate, but he's gonna come right back up. So it's a sudden drop or abrupt drop in the heart rate, and then it has a quick return up back to baseline. Okay, and it goes from here, and then he goes for a while, he's just fine, got variability, and then all of a sudden he does it again, and this time it can maybe look like this, and then he goes back over on his cord, so it drops again, and then he comes back up. Okay, we can change mom's position. If she was on the right side, maybe flip her over to the left side, maybe sit her up, different positions, get the pressure off the cord, because variables are caused by cord compression. Okay, so that's what variables look like. Okay. All right, so we done, let's see here, let me close this up here. So we've got here, so we got the variables. I showed you that. Cord compression, the earlies are caused by the head coming down. Accelerations, I showed you on that monitor strip about the accelerations. And then late decelerations, I showed you what a late deceleration actually looks like, and that's caused by uterine placenta insufficiency. That just how I learned this many years ago and remembered it, is that my uterus and the placenta, okay, they got to get along in order for baby to get the blood, correct? Yeah. Okay. So when they don't like each other, all right, that causes a decrease in blood supply to the fetus, decrease oxygenation to the fetus. Therefore, the baby's going, hey, I'm in here. You just gave me a contraction, which is a lot of pressure on me, and I can't tolerate it anymore. I don't have enough residual oxygen to continue in here, and I'm going to check out pretty soon. So help me, nurse. And that's how baby talks to us through the monitor. Okay. Now, here is an example of a late deceleration. Remember the nair. This is your lowest portion of your deceleration is after the contraction. Okay, and here you can see I'm losing variability. Had a little bit in here. See the squiggly line? Had a little bit more, okay? But I know I'm going to start losing it, and sure enough, I do. And that baby's becoming hypoxic. Okay. All right. So let's see. if we have a nurse and she's caring for a patient in labor and she knows the fetal heart rates are in the 90s after a contraction, okay, which intervention, priority intervention, should the nurse perform?
2.
Well, you could change it to you could turn it to the side, and what else would you do?
4.
And apply the prevention.
Take deep breaths.
You want to call the doctor. Yeah,
Oh.
call the doctor. Remember, write this down. Late decelerations are a non-reassuring pattern. Okay, they're not good.
Not the mother.
They need immediate attention. Immediate attention. So usually we have them already on their side, but if they're not on their side, you can turn it to a side, but also you want to get that doctor in there. All right. Now, before I move on, does anybody have any questions about fetal monitoring? Now is your time. Okay. Well, then I'll move on. All right. Just going over our amniotic fluid. Remember, color is normal if it's clear fluid. Okay. When you have like a green stained fluid, brownish looking fluid, that means the baby has already passed his first bowel movement, which is called meconium. Okay. All right. That can lead to fetal compromise. You know, when we have thick meconium fluid, we usually babies will show us on the monitor that, you know, they're not doing well in that environment. So we can do an amnio infusion. Remember that? We can put back nice saline, sterile saline into the uterus to dilute that green, mucky looking fluid so baby has a better chance of getting good oxygenation while in utero. Okay. And you always want to keep that back of your head, okay? Because you know your delivery is going to be a little different if you have a baby that's got meconium, because as soon as that baby's head emerges, you've got to suction, okay? You have to suction out so that you get some of that meconium out of his mouth, right? And then you take him, the rest of the body will come out with the next contraction, and you take him over to the warmer. Do not stimulate that baby to cry, and let RT go ahead and go down deeper. They will go ahead and tube the baby, put it into the tracheal tube, and suction deep. We want to get as much meconium out. And the reason why we're doing that is to prevent meconium aspiration syndrome. Okay. All right. Amniotic fluid should not really smell. Okay. If it has an odor to it, it could be definitely an infection. And that's what you have to remember in any type of wound that you deal with, is that if the fluid that's coming out, if that has an odor to it, that means that patient has an infection. Okay. And then you're always going to, you know, look at the amount. You know, scanned will be a triple, moderate is like about 500 mLs, and then large is about 1,000. All right. So here we go. How about here? A woman in active labor experiences spontaneous rupture of membranes. So which nursing action are appropriate at this time? All right.
A, B, C, and D.
Absolutely. You got it. Okay. All right. All right. I already kind of went over this with you. I talked about a doula helping the woman to cope with labor, kind of highlighted it for you. Yeah, you want it, you know, it's over there. They're very, very good. Okay. All right. So let's go over it now. Okay. So now you know how the uterus reacts in labor. Okay. We went over how the contraction, the powers dilate and open the cervix. We went over how the baby comes down the passageway and finds his way out. Okay, we did all that. Now we're going to take labor. because that was called the birth process. Now we're going to take labor and we're going to look at labor. So first stage of labor. So labor is divided into 4 stages. 4 stages, okay. The first stage is your longest stage. That's where everything's happening. You know, she's got a dilated face. All right, so we broke that down to make it a little bit easier into different phases of the first stage of labor. So the first phase, and I'm saying PHASE. Okay, that's when your patient is around from, you know, maybe she's just starting, so it should be 0 to maybe say 4 centimeters. Okay, and you know, she's very, you know, active, and she's, you know, really nice, and you know, how are you? Oh, nurse Florenzi, I'm so happy to see you again. Here I am in labor, stuff like that. Okay, I think that's about, I would say, from 0 to 3. And then your second phase, which would be the transition. Now she goes from 4 to 7 centimeters, and she is like, this is labor. Okay, this is labor. All right, she's real active. Now, if she's going to get an epidural, that would be a good time for an epidural, because now her contractions are going to increase. They're going to get longer and they're going to get stronger. Okay, so as I said, that'd be a good time for an epidural. All right. Now, based on her labor, it can go, you know, different hours. Well, we get her relaxed, she'll do better than if she's really uptight. This is where you're breathing. Now, if she has a non-medicated labor, she means she's not taking any medications. You really have to work with your patient and breathe with your patient, and you're at her bedside. Come on, let's breathe together. Let's in and out. Okay, we have the contraction coming. Okay, and now the contraction's over, and release it. Let it go. Relax. And we'll get ready for the next one. And then when she starts another one up, you start to help her again. This is without medication. Okay. All right. So it's a real active time. In the last phase is called the what? Transition phase, right? So I got latent, I got active, and I got transition. Okay, that's now I'm dilating from 8 to 10 centimeters. Now, if I'm a natural birth, I'm going to feel a lot of pressure. This is where you're going to tell her when she says, I got to push. And you say, well, let me check it real quick. You say, not yet, 8 centimeters. We got a little bit of cervix left, but I feel really a lot of pressure. This is where you're at her bedside. You're really right there with her, and you're telling her, look at me. I'm going to tell you to blow out the candle. And I always use my finger, guys. And this is true. This is what I did. I used my finger, and I said, this is a birthday candle. Now, puff your cheeks out and blow out this birthday candle. And that's what it takes for them not to push. Because she's feeling a lot of pressure, and it's very hard not to push. But this is where it comes in very much so that you need to really tell her to blow out. Puff your cheeks. Now, that's a good test question, by the way. So take note to that. You know, really puffing them out. Because if you puff out your cheeks, you can't push down. And you can try that later. Okay, you just can't. You can't push down while puffing at your cheeks. And you got to literally puff them out. All right. So that's your transition. Now, say she had an epidural. Okay. An epidural, you know, they kind of, some of them actually sleep through transition phase, and they sleep through even the, or they can sleep through the active phase and the transition phase. You know, they really do. Sometimes I had to wake my patient up. When I saw an early deceleration on the monitor, I said, oh, that baby's coming down, got head compression. I checked my patient, sure enough, she's complete. Okay. So if she's got a good epidural, a lot of times they can't even push. So we'll actually let the epidural, the medication to wear off just a little bit so she can feel some pressure. And when they feel that pressure, then we call that friendly pressure. Okay. I know I have all kinds of names, friendly pressure. And then I say, okay, next time you have that pressure, we're going to start pushing. So now she's complete. We're pushing. We're in the second stage of labor. It's the pushing stage with the delivery. Okay. Okay. And we're going to have that baby. He's going to be birthed. Now we can push from anywhere from 30 minutes to 2 hours. Now, depending upon how big the baby is, what position, Clarincia, go ahead and put yourself on mute. What position the baby's head is in, will, and like if he's in OP position, she's gonna push a lot harder and longer. OA is much easier for them to push out. Okay, if it's a big baby versus a smaller baby, they take a little more time to push. Okay, and then once we get the baby out, then she's done with that stage. We go into the third stage, and that's the placenta. Now, the placenta should never be rushed. Okay, placenta has to come off that endometrium, right, of the uterus. So with the contraction helps take it off, and then all of a sudden she's going to feel some pressure, and she'll say, I have to push again, and then she pushes, and then we deliver the placenta. Okay, all right. And when you look at the placenta, we're looking at it to make sure that it's coming out in entirety. Okay, there's nothing missing. There's no lobes to the mom side, which is called the Duncan side. There's nothing missing. So we know that there's nothing being retained up in that uterus. Okay. And then we look at the shiny side, which is the newborn side, the neonate side. And that's called the Schultz. And I call it the shiny Schultz because that's how I was taught. And I remembered it that way because it's nice and shiny and new. And, we look for how many cords there are. And I just read 3 vessels. Remember I said Ava, you have you have artery, vein, artery. So we should have 3 little vessels in there. And then the placenta comes out. Great. After the placenta comes out, baby goes to the warmer. Okay. And then we do the APGAR score on the baby over there. And the RN will be in the room. As soon as the placenta comes out, she pushes oxytocin up in the IV bag in order to deliver this patient to have oxytocin, because that oxytocin now, after the placenta is out, will make the uterus contract and keep her bleeding to a minimum. Okay. And then the 4th stage of labor is your recovery or your postpartum. And the recovery usually lasts 1 to 2 hours in, say, if you have an LDR room, it's the labor delivery recovery room. You stay in the room. She stays in the room and she'll recover in there. And then you'll get her all cleaned up. And baby will bond with mommy. And mommy will breastfeed in there. And then baby goes to nursery just to get an assessment done. Mommy gets cleaned up and go to mother baby unit. Now, if you work in a hospital that has an LDRP type of unit, that's labor, delivery, recovery, and postpartum room. And so mommy never comes out of the room, okay, until she's actually discharged from the hospital. Those are nice setups too. That's all according to how your hospital is set up. Does anybody have any questions about the stages and the phases of labor? Okay, then I will move on and put in here a little bit about pain management in labor. Now, remember I said the best time to get an epidural is during the active phase of the 1st stage of labor. That's when she's anywhere from 4 to 5, 6 in there. And that's a good time because that's the hardest time during the active phase is when she's going to do the hardest laboring. All right. And so again, you want to, work on that. So here you got an epidural. All right. So I'm showing you here with the epidural space. It's always good to understand what you're learning. And then here they put the catheter in. See here? Okay, epidural space. And that's why positioning of the patient, see this one, she's on a side laying position and she's got her knees up. That's hard for OB patients to do. How we do it is we have them sitting up. The nurse is standing, sitting up on the side of the bed. Okay, so she's got her feet dangling and I give my patients a pillow and they bent over like a mad kitty cat and they push their lower portion of their back out toward the anesthesiologist, okay? And then so he can see, that's what he's doing here, see? And he's looking for the epidural space. And they use a glass syringe, has to be glass, and sterile. All this is utmost sterile. And then he takes a syringe and there's nothing in the syringe, okay? And so he's pushing a little bit of air, okay? He push. And once that syringe lets go, okay? There's no more resistance in that syringe, then he knows that he's in this epidural space, okay? And then he'll say, okay, Irene, I'm there. I said, okay. So I tell my patient not to move. No movement. Now she could have a contraction, okay? And we try not to do this. We don't start this during a contraction, but it might be that it took a little time to get to the epidural space. And so it might be that another contraction started. And I always hold my patients. I said, just put your head down on my chest and bear your head down. Don't move. And we usually get through it. And so because we don't want to have this little needle here is going in to hit in the spinal column where there's cerebral spinal fluid, because then she'll get a terrible headache. Okay, so that's an epidural. What you have to worry, okay, about epidurals, okay, is a lot of times this epidural can lower their blood pressure. So it can cause hypotension. So that's a big worry that we have to think about when we're doing an epidural with a patient. So a lot of times in a normal patient, normal blood pressure, everything's good, we'll go ahead and give her a bolus of IV fluid. And we usually give about 1,000 mLs of LR prior to this epidural. So we get that on board in order that we can stabilize her blood pressure when she gets that epidural. See, so you're increasing the blood pressure just a little bit with extra fluid, but when she gets the epidural on the medication, they'll basically will equal out. And so that's what we're trying to do. All right. And so it works really well, guys. It really does. And anesthesia will give an order for that. All right. So let me see, I got the hypertension, epidural. You have to worry about, again, this needle going too far, because she can get a terrible headache after delivery. And those headaches are really, really cruel. And so a lot of times we'll have to do a blood patch afterwards. And what we do is we take out 10 mLs of blood, of her own blood. So we do a venipuncture in the antecubital space, and we'll take out 10 mLs, and it's all sterile, and they will go back in just like they're doing epidural, and see here, right in here where they were, and they punctured a little hole here that causes her headache. They'll take it and they'll push the blood through, okay, and they'll cause like a clot right in here, and that will seal that little tiniest hole, because don't forget, this is a real tiny thin needle, and seal that up really nice, and she will no longer have a headache. It cures it like instantaneously. It's just wonderful. Okay, so that's a blood patch. That's why you want to keep your patient still during an epidural. All right, but it works wonderful. epidurals are great for labor pains. They do take away the entire pain of the contraction. Maybe they can feel a little pressure, but nothing more than that, nothing more. Where if you give her pain medicine during the labor, she requests some pain medicine. The pain medicine doesn't take away the pain associated with the contraction. What it does during that relaxation time between contractions, then she'll be able to really relax during that time. Okay. And then she gets ready for the next contraction, which she will feel. And then after, when it starts to come down on the decrepitment, she will be able to relax more. So that's the difference in narcotic analgesia versus anesthesia. Okay. Now, another type of pain relief we can give is called a pudendal block. Now, you're going to give this during the second stage. Okay, she's completely dilated, she's pushing, and the practitioner has analyzed that he needs more room. So we may have to cut an episiotomy. And so we go ahead and, in the perineum, woman's perineum, inside you have what we call some nerve endings, pudendal nerves, okay? And so we take a long needle and we'll go inside and we'll numb up those nerves, okay? And then she really doesn't feel anything after that. And we can use that to do the episiotomy. It's nice too, if they're going to use a forceps assisted delivery, that they do a pudendal block. Okay. Again, she's got to be completely dilated. She's pushing. She's almost ready to deliver. We decide that we need a little bit more room. We're going to do an episiotomy. Okay. And so we do that. Again, it's during the second stage. Okay. All right. Let's move right along. A lot of questions on tests, they do focus on non-pharmacological childbirth preparation. So you want to make sure that you really understand all these non-pharmacological ones. So when you say non-pharmacological, that just means it's without medication. That's all it is, okay? And so if I'm going to teach you to relax, maybe do some skin stimulation, rub your tummy, do some effleurage, some sacral pressure, thermal stimulation, maybe some hydrotherapy. Oh, that's really nice. Water, okay? A lot of times I threw my patient in the shower. They loved it. They say that I'll just stay in the shower. And then I can see some bloody show come down their leg. I was like, I think we're doing good. We got some bloody show going. Looks like the cervix is starting to open up. And sure enough. And controlled breathing, that's another one. So that's a good all but apply question. So I would definitely make sure you know them. And then we have the childbirth preparation classes. They're all good. You got the Bradley method, Dick Reed, and the Moss method. All good, all control, keeping the patients in control, keeping her breathing in control, and everything does good. Okay, let's move right along. We talked about vaginal birth as a cesarean. I'm sure you've heard this already. It's called a VBAC. The main thing about a VBAC is that you have to make sure what kind of surgical incision was made on the uterus. So if it's a transverse, she can VBAC. If it's a classical or longitudinal, she cannot VBAC. Okay, because remember, you can't VBAC. You can't induce a VBAC. You can never, ever, ever give a VBAC Pitocin, because that would rupture her uterus, okay? So, a lot of ladies like to do this, and we have a big consent form, very long, and there's a lot involved because they have to go into spontaneous labor, because I told you, you can never induce them. And so, sometimes they start in spontaneous labor, but then they start to dwindle out, and you have to augment them. Remember, add to the labor, but you can't augment with these patients because you can't augment with Pitocin. So what happens to a patient that gets stuck then at 6 centimeters? Well, she's probably going to end up with another cesarean section. Okay. So again, we're there for support. Whatever she wants to do, we're there. As long as she goes into spontaneous labor, she's okay. All right. So here's a brain teaser. You ready? So the nurse is caring for a woman who's delivering her first baby. Okay. Which of the following indicates the woman is in the third stage of labor?
D.
D.
D. Good, good, good. Notice how those questions are worded. The nurse is observing a patient for hemorrhage following a delivery. Which assessment finding indicates a maternal hemorrhage is occurring? And this is a select all that apply.
A, B, C, and D.
A, B, C, and D. Absolutely. Right. Okay, good. All righty. The next one. Ready? The nurse is assessing a client post-delivery, knows the uterus to be high and displaced to the side. Which is the nurse's priority action?
C.
What was that?
C.
B?
A.
You said-
No, C.
C.
As in cat.
Yeah, C is a cat. You got it. Okay, good. Okay, good, good. All right, how about the next one? Which nursing intervention should the nurse include for a client immediately after delivery to reduce bleeding and bruising of the perineum?
Ice pack.
Ice pack.
D.
D, good. Okay, moving right along. Okay, so I talked about amnio infusion already, but when we have that meconium amniotic fluid and we can dilute it. Okay, induction of labor just means that we are putting someone into labor. Okay, that means you had your post dates, and my goodness, she's gone to 42 weeks and she's not going into labor. She is cooked. So she wants to be delivered. So you're going to do an induction of labor. First, though, in order that we want to be successful in our induction, we're going to do a Bishop score. And the Bishop score basically is looking at the cervix, how much is dilated, the effacement of the cervix, the length of the cervix, the station of the baby's head. Okay. So what you have to remember, a minimum score of 6 is recommended by the American Congress of Obstetricians and Gynecologists, okay? Because then we know that we'd be able to induce this woman. If she's below a 6, that means that she's probably not dilated, she's not effaced, the baby's head is probably high, the cervix could be actually facing to the back of her, the posterior position instead of anterior, and then cervix is the length of it is long. All right, that's not someone who you want to start inducing on, because you're not going to make it. All right, end up with C-section. So we do some cervical ripening. So we use 2 types of drugs for cervical ripening. It's called Cervidil or Prepidil, and they're both prostaglandins. And prostaglandin is a substance that you need in order to irritate that uterus to make it contract. Okay, so that's induction of labor, real quick. And then augmentation of labor is where she's already in labor and maybe she had an epidural. Okay, because this happens. She has an epidural and her contractions are now very mild instead of where they were. They were firm before, and now they gone down to mild, and their frequency has spread out. Okay, so I have to augment. So I have to give her Pitocin in order to enhance the labor pattern. That's called augmentation of labor. So just read those type of questions really carefully, and you always ask yourself, what's that question asking me? If it's asking me about induction of labor, you know what to do. And you're asking if her labor has slowed down, then you know that she's going to be augmented with Pitocin. Okay. Now, there's always a contraindication. These are people that you do not want to induce. Well, one is that VBAC I told you about. You never induce her. A lady has placenta previa. You remember what placenta previa is? Right? The placenta is right over the cervical os. You're not going to induce her. If you do that and make her contract, she's going to hemorrhage on you. So that's never going to happen. All right. If you have a cord prolapse, and a cord prolapse is where the cord now is coming down the side of the head of the baby and comes right through the cervix, that could be because the baby's head is really high up. So the cord had ample room to just kind of loop down, to drop down. That's called a prolapse. You would never induce that kind of patient. Any kind of abnormal fetal presentation, transverse line, shoulder presentation, a breech, you're not going to induce them either. A high station of the fetus, again, you put at risk for prolapse cord because the baby's too high the pelvis. Active herpes, we're never going to have a patient has active herpes is not going to deliver through the birth canal. So we wouldn't induce her. And then if she doesn't have a good pelvis, you wouldn't induce her. She had a planetoid pelvis with those real flat looking things. You're not going to induce her. She wouldn't be, you're not going to be successful. So why would you put her through an induction of labor with Pitocin? Because Pitocin contractions are tough. I mean, we try to mimic labor. We only use milliunits in the Pitocin, so it's a really small amount. But again, and labor is not easy. And then any kind of cesarean incision. If you have a longitudinal incision on the uterus, you're never going to induce, even transverse, because labor induction means you are using Pitocin. Okay, all right. Let's move on. These are some complications that can evolve during the labor and birth. Okay, so we got your induction or augmentation of labor we just discussed. We talked about the Bishop score. Amniotomy is rupture of membranes. Whenever you assist in an amniotomy, you always want to make sure they got plenty of chunks underneath the patient because a bag of water, they're going to break a bag of water. You always want to check fetal heart tones. Okay, and you always want to make sure that that cord didn't come down along with the rupture of membranes. Okay, amnio infusion. We talked about that. Putting fluid back into the uterus. Aversion, where they go from a cephalic position. They go from a breech position up to they'll turn the baby to cephalic. Okay. Episiotomy and lacerations. Let's see, forceps, vacuum extractor. Forceps and vacuum extractor. They're tough, okay? They're going to be used during the second stage of labor. They could do damage to her vulva and her perineum. So you be careful. Mom can have very sore tissues, and baby can get paralysis of his face. And the vacuum extractor, you can get like a circular mark on his head during that time. They're good. I prefer a vacuum over a forceps, but it's tough. It's tough on both mom and baby. We talked about cesarean, abnormal labor, where she doesn't progress like she should, going to the Freeman curve. She has an abnormal progression and dilation. Let's see here. You have problems with the powers of the labor, which is your contractions and birth process. We talked about prolapse cord. So let's go ahead and continue real quick. So here, this is about your lacerations or episiotomies. So again, you're opening up the area, the perineum, to allow the head to descend and to come under that symphysis pubis so it can be born. A lot of times the head, it's the biggest part of the baby, and so it's coming through a really tight area. So mom, her skin stretches usually very beautifully enough to open up nicely, but sometimes she needs a little help. So we'll do a degrees of episiotomy. So the first degree is just really the superficial top portion of the skin. Okay, then each degree goes a little bit deeper. So second degree, you're getting a little bit more of the skin and getting into the deeper tissues of the perineum. Okay, getting a little more. Now I'm going to cut more third degree. Okay, I'm getting into the sphincter area. Not a good area. And then fourth degree, I'm cutting all the way through everything. Okay, and I'm going down to the anal, through the anal sphincter into the rectal mucosa. Those are what are 4 degrees of what we call C-section from below. Okay. Now, in any of these, you put ice pack on the first 24 hours. Please do that, because an episiotomy is going to be red, it's going to be swollen, you're going to have bruising or ecchymosis. So you want to make sure that you got ice for that, okay? All right. Here, this is just shows you, I just talked about the forceps with you. These are stainless steel, by the way. There's no giving in. That baby coming out, that baby, that's gonna be right applied right to his head. Tough, it's tough. Vacuum, it looks like this, see the circular, and that leaves a little mark on his head. It does go away though, and it's a little bit better. What happens is either one, the forceps or the vacuum, these are what we call assisted devices, okay? And so we use these to help mom. So mom will be still pushing. We're using the assisted device to, when she has a contraction. Now, only when she gets a contraction does she push. So if she has a contraction, she's going to push. Mom's pushing, and then we're assisting and kind of helps her get over that little hump area where it's very hard sometimes to get through. And that's why we use those. Again, this trauma can happen to her tissue or the fetus. And the biggest one is your hematoma in her vagina. Usually around the vulva area, you get a collection of blood, and it's very, very painful, very painful. Okay, so what would the nurse expect to assess in an infant who was delivered with an assistance of a vacuum extractor? Which one? Anybody? Anybody with me? And remember the vacuum. So the vacuum is, remember, it's in a circle.
Yeah. So it puts a sacral,
Circle
yeah, edema under the scalp.
Right, exactly. Now, a facial paralysis would be the forceps.
Yes.
Okay, good. Okay, good. All right, let's do another one. Which will the nurse expect to observe in an infant delivered? Oh, that's the same one. Okay. Well, that was easy enough. Okay, so now let's do the 4th stage of labor, okay? So we can take her vital signs, we take her temperature, make sure she's not running a temperature, make sure she has water at her bedside, she's got an IV, make sure her pulse. Now, what I want you to know to the pulse, okay? Normally after delivery, they have a low pulse. So we call it more bradycardia, okay? And if they have a high pulse after delivery, then you better be looking at a couple things. One, they could have an infection. So then you would really make sure you took a temperature. And number 2 is she could be bleeding. So you want to look at her lochia, okay, to see if she's having a lot of lochia, okay? Because when they go into, when they're bleeding out, all right, then the first sign of a patient going into hypovolemic shock would be tachycardia. So that's why that's so important to really know what your patient's pulse is after delivery so that you can tell what's going on with her. And then, of course, you check for edema. And then, of course, you're going to check for the Holman sign or a thrombus, because a positive Holman sign is not good, okay? That's when you dorsiflex her foot and she complains of pain in her legs. Okay, and then you touch it and it seems a little warm to the touch. That's not a good sign. Okay, so that's called a positive Holman sign. All right, remember in your book, it was in your chapter that you just basically read, and it had the mnemonic for bubble heat. Okay, so it goes over everything that you're going to assess during the recovery time of the postpartum. Okay, so that's, and the Holman sign is one of them. Okay, all right, let's move on real quick here. So we're going to go to cesarean births. Okay, so remember, we have two ways of delivery. Vaginal delivery, because everybody wants to have a vaginal birth, but we can't get the baby out to the vagina. We're going to go ahead and do a nice incision and do a cesarean. Okay, so it is major surgery. Okay, it is major surgery, and so it's treated that way. She goes to recovery and make sure that she recovers well. Usually they have an epidural. Okay, if they've been in labor, they'll have an epidural, and we just go ahead and give them more of the medication to numb them a little bit higher than they had for going for a vaginal delivery. But you have a patient that doesn't make progress. She can't push the patient, put the baby out. Maybe she's got active herpes. Maybe she had a previous surgery on the uterus. Okay. You have late deceleration. So that's fetal compromise. That was never good. And so you're going to get the baby out. And then you may have where the placenta previa, the placenta's over the internal os. And you can't do a vaginal delivery through that. So you're going to have cesarean. Or you may have an abruptio placentae. She comes to the triage door and she's complaining of a lot of pain in her abdomen, and you touch her and she's got this rigid abdomen, real rigid, hard, and she has an abruption. And you have to get the baby out quickly so that baby doesn't get compromised. And so you're going to do a cesarean delivery. Okay. All right. Cesarean's good for, you have multiple fetal pregnancies, twins, triplets, quads. You get, you want to get them out. Okay. All right, let's go on real quick here. So, again, when you're monitoring her after a cesarean, you're in the recovery room with her. Okay. So you're doing everything you would for a vaginal delivery, and then you would monitor her, you add to it, monitor her abdominal dressing. Check her fundal height. Okay, yes, you do on a cesarean. We got to make sure that uterus, remember, got to make sure that uterus is firm. Okay, so she doesn't bleed. Okay, but a heavy bleed. Lochia is usually less, but it's rubra, because rubra is 1 to 3 days after delivery. Urinary catheter she'll have, so you got to monitor that. Do her I and O, and respiratory care, deep cough and deep breath. And then you're going to be checking for a thrombus, because after delivery, during pregnancy, clotting factors are higher, and she's prone for a thrombus. So that still occurs after delivery. So you're going to be checking, make sure she doesn't have a thrombus. And of course, you're going to take care of pain management. Okay, so which will the nurse anticipate assessing and applying following a cesarean delivery? Select all that apply.
A, B,
All of them.
E, E.
Yeah,
All of them.
is that a trick question? Okay, yeah. You're gonna watch. Okay, so how about this? They always like to put a Kegels exercise on the test. So which information will the nurse include when discussing Kegels exercises with a postpartum client?
A.
Yeah.
Yeah, good. Okay, you got it. You guys are good. All righty. APGAR scoring, you just had this, I think, but we'll go over a little bit because they might have a score. And in your HESI book, it's a really good chart. And let me tell you what page is on. It's on page 196, and it has your it's called the APGAR assessment. And it's table 6.3. And this is what we're looking at. We're looking at the baby. Like here you have A for appearance. So that would be the skin color. See, this is what they did. They got this indicator here, this mnemonic, APGAR. Kind of nice. Kind of easier for you to remember. So A has how this baby's looking. All right, so the skin color. So if he's blue, he's going to get a 0. If he's like got a nice pink body, see here? But his little legs and feet are blue, he gets a 1. Give him some credit. And then if he's all pink, he gets a 2. Now, this little guy here I'm circling around, that's called acrocyanosis. And that's okay. And usually they'll come out of it usually after 24 hours. Okay, and a lot of babies come out of it like within 10 minutes, 5 minutes after birth. It's just according to how wonderful when these three shunts in the baby's heart, how they close, is how much blood is being pumped out to the peripherals. And that's all that is. So it has to give them time for that heart to pump out enough good oxygenated blood to get these to turn pink. That's what happens. Now, the P stands for pulse. So obviously, if you got no pulse, you're going to give it a 0. If you got less than 100, you give them 1. Greater than 100, you give them a 2. All right, and then here you got G for grimace, because a lot of questions, especially on HESI, they refer to this as grimace. And so this is his reflex. All right, so he's like, if he's floppy, just laying there, must have had a tough delivery, then you give him a 0. You got to stimulate this baby. And then minimal response, you give him a 1. And then he's got some kind of response, you give him a 2. And it goes down for activity, he's nice. I love these babies when they're nice and active. And then in respirations. Respirations, if he's got no breathing, obviously is a 0. And if he's got a weak or slow, you give him some, again, you're going to give him some credit. And then in a vigorous, strong cry, I love it, I love it, I love it, you get a 2. So if you have a severely depressed baby, I mean, they come out flaccid, they're not breathing, the heart rate maybe like below 100, maybe 90. He's got minimal response. If he got like from 0 to 3, he's severely depressed. You need to do some good resuscitative measures on this baby. If this baby comes out and his APGAR is between a 4 to 6, you have to do moderately, get in there, get that. I usually stimulate the baby, when I'm here and I'm drying them off. And I usually use a good vigorous drying off. They get irritated, they cry, they give me a good cry, and then all of a sudden they give me a good cry, and all of a sudden they're pinking up. All right. And then of course, if you have a baby that has 7 to 10, that means everything is good. Maybe he has got 1 off for color, but usually my babies were about 8 to 9, and several good babies. Okay, excellent condition. That's what you want. So a good question on a test would be, baby has from from 4 to 6. What type of resuscitative measures would the nurse do? Okay, and so that's the kind of question that you would look at. Okay, let's go down here now. So let's go here. Oh, sorry about that. I made it bigger for you. So let's talk about security measures. So which security measure will the nurse take when bringing the client's newborn from the nursery to the mother's room?
D.
D. Yeah, D. That's a good one. Okay. And they do like those kind of questions. Okay. This I put in here. HESI likes you to know the normal vital signs for infants. Okay. So just, put in your brain, because you're going to have this in term newborn next chapter, I think. So you want to make sure that you know these. Okay. So, Florenzia, go ahead and mute yourself. Know these. Okay. All right. So that you can recognize the abnormals. That's what I always tell my students. Know the norms, okay? So you can recognize when something's abnormal. All right. So which of the following interventions best promotes bonding following a delivery?
B.
B. B as in boy?
Yeah.
Yeah. Okay. Skin to skin, always. Okay, good. Okay. Breastfeeding, there's 2 hormones that you need to remember. Prolactin hormone, which is involved with production of milk, all right? And then oxytocin causes the milk letdown, okay, or the milk injection or the letdown. And so these are 2 hormones that are needed for breastfeeding, all right? Okay, and that's why after your baby comes out, and everything is good, you put the baby skin to skin on mom, okay, that's for your bonding, and then you have mom breastfeed. Mom will then produce her own oxytocin, okay? And you now got more oxytocin going in her system to contract that uterus. So therefore, your uterus gets firm, okay? All right. So that's another trick. And I always have my patients breastfeed right at the delivery. Now, you have to know the phases of milk production. So again, colostrum has your protective antibodies, which is very important because babies are only born with 1 month passive immunity. So you want them to have the protective antibodies in the colostrum. Okay, so that's why I want you to know there. All right, moving on. All right, let's see here. Very important to know the latching on. A lot of questions can be, or one question can be on latching on. You want to make sure that the mom's, this brown part of the breast, which is the areola, you want to make sure that whole thing gets into the baby's mouth. Okay, see mom trying to do this here, and here she's successful. That's because a lot of infections in the breast have been caused by babies just grasping onto the nipples. And mom's nipples get cracked and they start to bleed even. And then she can get an infection through the crack. And then she has a condition called mastitis, which is inflammation of the breast, which is very, very painful. So we want to make sure that your baby latches on. When your baby latches on, you gotta, when you gotta take the baby off the breast, okay, you have to make sure that you create a brake suction. Okay, so here she takes her finger and she puts it right in the baby's side of his mouth and just gently just puts finger in there and that'll break the suction. Okay, and that works just like a charm. You can't just pull the baby off the breast because that will hurt mom tremendously. Okay, and so we don't want that. Moms that don't empty the breast properly. Oh, I have somebody in the chat. Okay. All right, Lauren, I'll see ya. No problem. All right. Let's see. Okay. Mommies that don't feed enough can get engorged. Okay. Mommies that are not going to breastfeed can engorge. Now you can see here the difference in the tubules right here. See this? Look, this is engorgement. This hurts. See these milk glands? These all hurt when they're like this, okay? So you don't want this to happen, all right? So in order to avoid that, she's gonna wear a good tight bra, okay, in between feedings. And then you can put some cold, oh yeah, Clemensia.
It's funny that it looks like the engorgement looks like that in the breast on the picture because that's exactly how it feels. It feels like little lumps.
Yes,
under
very
your
lumpy.
breast. Yes.
Very lumpy. And it hurts.
Yes, it does.
It hurts. So what you can do is you can put like cold packs on it, and then in between feedings, you put the cold packs on. And then just before she's going to feed again, you can put like a little warm compress on it to get the milk going. And that really works. And that helps with the engorgement. Now, if you're not breastfeeding, then you have to reduce the stimulation to the breast in order to suppress the lactation process, because the body will normally keep going because that's what it does. But eventually, when there's no stimulation to the breast, that process will keep going backwards, keep going down, and you won't have that anymore. Okay. This is what mastitis looks like. Okay, so mastitis, this is what you want to prevent. So that's why you want proper latching on the breast during breastfeeding and proper break seal. You want to make sure you get in there and break that seal. You don't pull the baby off the nipple because this is what happens. It gets very heavy. This hurts. Actually, the infection can go up underneath her armpit into an area we call the tail of Spence, and all that. She can hardly walk. You can't touch. She needs antibiotics, and she cannot breastfeed out of this breast. Okay. Now, A lot of ladies are not comfortable. They say, well, how do I know my baby's getting enough fluids? Okay, well, I don't blame them, because the colostrum is very thin looking, okay, but it has such good antibodies in it. So we want them to breastfeed. But I always tell them, if your baby has at least 6 to 8 wet diapers per day, he's getting enough fluids. Listen to his swallowing when he's feeding, okay? And the babies, after they feed, they're relaxed. Their tummies are full, and they're relaxed. So again, this could be a question. I know you're all going to get this. Which of the following indicates successful breastfeeding is occurring?
A.
A. Yeah, that was easy. All right, let's try another one. Which nursing action best provides a postpartum client pain relief from breast engorgement? Yeah.
C.
C is in cat. Good. You're doing good, everybody. Okay, let's move right along. You know that she needs 500 extra calories when they breastfeed. So that's how I get my young mummies to breastfeed. Tell them 500 calories, folks. Okay. Just note that whatever food mommy takes in goes right to the breast. So baby could get gassy. Weaning. Now, weaning is, there's really no best time, but what we try to tell mom is eliminate one feeding at a time and omit the daytime feedings first. Okay. And the last one should be eliminated would be the last, we call the nighttime feeding. It's called comfort nursing. And so that's a special time with mom. So, you could choose to get that one out, omit that one at the last. Okay. Let's see here. So this one's a good question because this one says the need for further teaching. So the lactation nurse has provided breastfeeding education for a new mom. When discussing weaning, which statement by the mother indicates the need for further teaching?
D.
Yeah, good. All right. Okay, we already talked about all that, so we're good. Let's go here. Okay. Hold on just a moment. We talked about amniotomy and the complications. Good. Let's go. We talked about that already. All right. Here, they always like to put in a nutrition. So what kind of diet should a woman have if she has a 3rd-degree episiotomy laceration following a vaginal delivery?
Like vitamin.
High fiber.
Yeah.
High fiber, right? High fiber. Fruits and vegetables. Fruits and vegetables. What else? And lots of water. Right? Remember, with a 3rd degree, you want to avoid constipation. It'd be the same diet that you would use if she was constipated, if you had a patient who's constipated. So it happens on med surge too. You want to give them a high fiber, you want to have them drink the water, right? And you want the fruits and vegetables. Okay. Which will the nurse expect to observe in an infant? Well, you know this, but we already had that. Okay, I think I got repeats here. So let me just go down. Let's talk about precipitous birth. Okay. What's a precipitous birth?
Birth that happens like less than 3 hours.
Right. Now, can there be complications related to this precipitous birth?
Hemorrhage.
Yes, complications, both to mommy and baby. So mommies can have a uterine rupture because you had too many contractions too fast, okay? That's called tachysystole or hyperstimulation of the uterus. So that could cause a uterine rupture. Mommy can have a laceration, which is, maybe a laceration of the cervix. Okay, high up is a cut. And, she could hemorrhage from a laceration, by the way. She could have a hematoma. Usually in the vulva area, they have a hematomas and there's a collection of blood. That's very painful, very, very painful. So you have that. The baby's oxygenation could be definitely compromised because he's coming down the birth canal very, very fast. That means he's not getting enough circulating oxygen, right? Think about it. You have contraction one after the other. There's no in between. Maybe you have a few seconds in between, but it's tachysystole is just one contraction after the other. So there's really no time in between to kind of give him oxygen. Birth injury, sure, from coming down through the canal too quickly. I'm thinking he could have an intracranial hemorrhage. You can get nerve damage. So these are deliveries that you hear like on the news, like maybe she delivered in the car. Her labor went really, really quick. These are things that can happen. So it's in a way it's not good. In a way it's good for mom because she's not in labor a long time. So if I was to ask you what type of complication could occur after a precipitous delivery, what would you tell me?
Hemorrhage.
Hemorrhage. Great. Great. Okay. Premature rupture of membrane just means that the membrane's ruptured before contraction started. So you want to confirm that. When somebody comes in and asks you about that, you want to confirm that with the nitrogen paper test. Okay, it's a litmus test. It's yellow, and when it blends in with mixed in with the amniotic fluid, when it touches the amniotic fluid, it will turn yellow, greenish blue. Okay, in case you have a question like that. Let's see. Premature labor. We use labor before, she's term. That's called premature labor. So basically the goal of anybody in premature labor would be to stop uterine contractions. We stop them by using what we call tocolytic therapy. Now tocolytic, you can see the name out here, okay? That reminds you of what? The toco on the monitor. So that would be contractions. And I'm going to stop these. So I'm going to use, the drug of choice that we do use is called magnesium sulfate. Now you say, I know that drug. We give that to a lady who's got preeclampsia. Yes, same thing, because magnesium is a central nervous system depressant. So it kind of depresses everything, all the different muscle fibers. And so therefore, it will do good, again, to stop the uterus from contracting. Okay, same thing. So that's what we want to do. We don't want this lady to deliver, so we'll give her magnesium sulfate. You have to monitor just like you normally would. You got to watch your reflexes. You got to watch your respirations because you don't want to give too much, because then what? You got magnesium sulfate toxicity. All right. So if I also, there's another drug back in the tocolytics. It's also another drug that is a prostaglandin inhibitor. It's called brethine. So write that down. Brethine, terbutaline. This is actually a bronchodilator, and we use it off-label to stop contractions. Okay. So you have to be careful with brethine though, because it increases what? The heart rate. So that's what this is. What's the nurse's priority assessment of a patient taking terbutaline? Is her heart rate. It will increase the heart rate. So you be careful with that, but it works like a charm, and we use it also. Okay, let's see here. All right. These, of course, anything, tocolytic therapy, anything we talked about, induction of labor, there's always contraindications. Well, I wouldn't use a tocolytic on a preeclamptic patient because she already has increased heart rate and increased blood pressure. So I wouldn't do that. Placenta previa, we don't want her contracting, but we also don't want to increase her heart rate. So, sometimes we do use it on a previa, okay? When abruption, they usually are not contracting that much. I could give them some fluids and probably get the uterus to relax. I don't need to stop anybody who's in labor over 37 weeks because that's term. I'm not stopping her. If mom has a infection in the uterus, which is called chorioamnionitis, that's when the chorion and the amnion are infected somewhat. We got to deliver this baby. Baby's in trouble. And of course, if you have a fetal demise, you wouldn't do that either. Okay, let's go on here. Some postpartum complications, shock, and we talked about hemorrhage. We talked about an emboli, DVT. You have DVT, PE, postpartum infections. Subinvolution is a term where there's you know what involution is, right? Involution is where the uterus contracts down like 1 to 2 centimeters per day, contracts back down to pre-pregnancy size. Subinvolution means it's just a slow return. Okay, she's not doing like she should, like 1 to 2. No, she's not doing that. She's doing slowly. So I would definitely look at her lochia here and assess and see why she's not involuting. And it could be that she has retained placenta fragments and therefore she's not involuting like she should. And then again, we talked about mood disorders, baby blues, and postpartum depression. These are mood disorders that can happen during the postpartum time, and of course, postpartum psychosis. All righty. These are just the different categories of shock. Most that we deal with, I'm going to be honest with you, is hypovolemic shock, because this is where we run into postpartum hemorrhage. And we treat a hemorrhage just like you're treating a cold blue. We actually say PPH in room 2. That means postpartum hemorrhage in room 2. Okay. And so you got to be very careful, and you got to be careful of the clotting disorder because, she's apt to make more blood clots. Okay, let's see here. We're almost coming to an end, so hang in there with me. So the first sign of hypovolemic shock is most often what?
Tachycardia.
Tachycardia. Yes. Good. Okay. All righty. Let's go on here. This is just your nursing care. Anybody that is showing signs of shock, you're always going to take frequent vital signs, give oxygen if necessary. So you have a pulse oximeter on her. You're always going to assess lochia and look for any kind of perinatal hematomas. Assess the fundus. Always, always, always. If you have a soft, foggy uterus, you're going to do fundal massage. Okay. You want that uterus to be firm so that she bleeds normally less. You don't want her bleeding out. You don't want to have a hemorrhage. Okay. So make sure that uterus is nice and firm. And then you have your accurate measure, of course. And then, of course, what was it? Hold on. Okay. A monitor for signs of anemia. We know how to do that. Real simple. Look inside their mouth and see if the mucous membranes are what? Are pink. Okay. And always provide emotional support to the patient. All right. The causes, early postpartum hemorrhage can be caused by the uterus not firming up. That's called uterine atony, and that's a uterus without tone. Okay, so that's never good. Okay, that's why you're going to do fundal massage. A laceration, remember we talked about that precipitous delivery? She gets a laceration or cervical tear. It's real high up, but they have a trickle of blood, okay? And they can have that. And then, of course, hematoma in the reproductive tract, usually in the vulva area, you have the hematoma, which is very, very, very painful. So uterine atony, lacerations, and hematoma all happen in your early postpartum hemorrhage. Now, we talked about that already. Okay, we're going to here. Again, uterine atony, a uterus without tone means that she's soft and boggy. That's what it is. And the fundal height is usually above the umbilicus. So if I'm assessing a lady in postpartum and, I see that fundal height really high, I'm going to be checking. Now, first, I'm going to check to see the bladder, make sure the bladder is empty. And then I'm going to check to see the lochia. Is she having bleeding with clots? Okay. Because that's why her uterus is not firming up either. She could have Sometimes they have retained placenta fragments up there, and it causes that uterus not to be able to what? To contract. All right, and that's the whole thing. Make sure it contracts. All right, so your brain teaser. Which medication will the nurse anticipate prescribe to control postpartum uterine atony? So which one of these would do that?
One.
No, not terbutaline. Terbutaline would be used for premature labor. So write down terbutaline, premature labor. Okay.
Is that 3?
3, methogen. So write down methogen. Okay. So you have methogen, and don't forget, right after delivery, we're going to give her oxytocin. Okay. So that also makes the uterus contract. And then she's still soft and boggy after with oxytocin. Then we may have to go to methogen. But we have to be careful with methogen because it increases the heart rate. So her pulse. So we don't want, you be very careful with that. But it works like a charm. You don't have to get that much. It's an IM injection, and it works just really quick. And it makes her have tremendous afterbirth pains. But you use methogen. So methogen would be used for that. Okay? Good deal. How about another brain teaser? The nurse assesses a postpartum client and and notice uterine atony. Okay, another one. So which action should the nurse perform first? What's the question asking you? She notes uterine atony or tony. That means a uterus without tone. If I have a uterus without tone, what should I do first?
Fundal massage the fundus.
That's right. Good. So now you see that. So did you see what I said to myself? When I was reading it, I had to go back and ask myself, what's this question asking me? And sure enough,
postpartum gives it away because it's after the baby.
Yeah, and uterine atony, a uterus without tone. So this tells you she delivered postpartum. This is where she has a soft, boggy uterus. That's what this one says. So what would I do first? Massage the fundus. You got it. You see how that connection? All right, let's see here what we got here now. Oh, we already talked about laceration, so we're good on that. How about this brain teaser? What is the nursing action that's appropriate in the care of a postpartum patient to prevent fundal displacement?
2.
2. That's right.
Excitation of void.
You got it. Absolutely wonderful. All right, we talked about subinvolution. And here it is, my slide on it, but we already talked about it. And the thing is, it's just slower than expected of the uterus to return to pre-pregnancy. So again, you might have a fundus that's higher than expected. You might have lochia rubra, persistent, too much, may have clots in there. She may have some pelvic pain and feel heaviness in her abdomen because the uterus is not going down like it should, and she could feel fatigued. All righty, let's see. Let's go on here. Let's do another brain teaser. Classic symptoms of a DVT, deep vein thrombosis, include muscle pain, a positive Holman sign, and swelling of the affected limb.
True.
Good. All right, you might see that one again. All right, if I'm teaching somebody to prevent a thromboembolism, I wanted to teach her not to cross the legs, okay, as we all do all the time. Avoid pressure in the popliteal space behind the knee. Get up and move. Like we've been sitting here for a long time. We need to probably get up and do some early ambulation and some range of motion exercises. Okay, and the signs and symptoms of a pulmonary embolism, they have difficulty breathing, coughing, and chest pain. Okay. How about this one? Your patient is 5 weeks post-vaginal delivery. During the doctor's visit, the patient states that she noticed a foul-smelling drainage, pelvic discomfort, and she's been running a slight fever. The nurse relays these findings to which of the following? Ooh. Okay.
Is it UTI?
Now let's go back up and take this question apart. Okay, so first of all, she's post-vaginal delivery. Then
Yeah.
she notices a foul-smelling drainage. No, her drainage.
Oh, drainage. Yeah, UTI, you don't drain.
Right, foul-smelling too. So what's
So
foul-smelling tell you? Is some kind of infection. Okay.
Yeah.
And I have
Endometriosis.
pelvic discomfort and been running a slight fever. And I just delivered. I'm 5 weeks post delivery. So which one of these? So we know involution's out because we know what that is.
Some of the placenta is left on the endometrium.
Endometritis. Absolutely. Okay, so there you see endometrium. That's what's happening. In her endometrium, she has an infection, which causes her to have endometritis. You see how we took apart that question?
Yep.
That's what you have to take the time on these nursing tests to do. You have to take apart these questions because if they actually the answer is right here in the question. Okay. Okay. So here, no, we're gonna have math on the exam. So you make sure that if it says round to the nearest tenth, you do nearest hundredth, whatever. Okay. Read it carefully and put some calculations in here for you. And remember, there's going to be one on this, calculate the I know. You had it on your worksheets. And this one, desired divided by what you have on hand times quantity. So, and you ran to the nearest 10. And you can see that this answer is not the nearest 10. So the nearest 10 would be 0.6. All right. And this is what we do it for. We do it for her to deliver a beautiful baby and to be a family. All right, everybody. I appreciate you all hanging in there with me. And we had a great review. And I hope you enjoyed it. And I appreciate it. I appreciate you. So I'm going to